Welcome to the module on aortic and acute abdominal emergencies. In this module, we'll look at the scanning of the abdominal aorta, but also look at this in the context of acute severe abdominal pain and how we can use ultrasound in our practice. So, acute severe abdominal pain, there is a very broad differential diagnosis. And before we get started talking about the different actual diagnoses, I want to talk about what is possible, what I believe is safe to try and include in this module. And then we need to recognize that for severe abdominal pain syndromes, the CAT scan remains the gold standard for many situations. Now, obviously, we don't always have a CAT scan available, and so therefore ultrasound can be a short-term measure. But for patients with very severe abdominal pain who may require urgent surgery, for example, CT remains the gold standard. Now, I think it's really crucial that we understand that POCUS is a useful tool in terms of ruling in serious diagnosis. It's typically not great for ruling out many of the diseases that we actually worry about in the emergency department. The integration of bedside ultrasound into our clinical decision-making can be very useful, however, and can be used to guide us as to where we're going with the patients. And of course, there are those geographical considerations, in that acute severe abdominal pain in a place with no CT or no surgeon is a very different beast to that in a tertiary emergency department, where it's quite easy to get access to advanced imaging and surgery in rapid time. And so sometimes POCUS is more used as a triage tool in this situation. So let's talk about some of the common differential diagnoses for acute or severe abdominal pain. Now, we're going to talk about AAAs and ruptures. To be honest though, ultrasound is traditionally used in this context either as a screening tool for asymptomatic people or in people with a known aneurysm in order to surveil the growth of that aneurysm over time. These are generally asymptomatic people, and when we're talking about people with severe acute pain, ultrasound doesn't have the sensitivity or the specificity to allow us to rule in AAA rupture, and it certainly doesn't have the specificity to help us rule out AAA rupture, because that can be very difficult to do. The same goes for aortic dissection. There are a number of signs that can be very helpful in pointing towards that as a diagnosis, but there's really no reliable way of ruling out aortic dissection with ultrasound in the emergency department. Mesenteric ischemia is a very difficult diagnosis to make, particularly with ultrasound. Once again, there are some signs that can help us rule it in, but it's hard to rule out. The ones that are actually quite useful in the emergency department, the common and less sinister problems such as biliary colic or cholecystitis, renal colic, and bowel obstruction are all actually diagnoses that we can rule in with point-of-care ultrasound or formal ultrasound, and they can really help us guide our management. It can be difficult to rule these out completely if you're following a limited protocol. However, they do tend to help us if the picture fits with, say, biliary colic and you can see a stone, then you know that that's where the likely pain's coming from, and we'll talk more about that in our biliary lectures to come. GI bleeding, really difficult to either rule in or rule out. That remains a clinical diagnosis and you just need to do what you normally do. Retroperitoneal bleeding is also very difficult to see on ultrasound and typically requires a CT scan to rule out. Pancreatitis, this remains pretty much a biochemical diagnosis in most people, along with the clinical story, and ultrasound is really very insensitive for pancreatitis. And once again, appendicitis, in trained hands, we can rule this in. However, it is very difficult to rule out with point-of-care ultrasound. Right, let's start with the abdominal aorta. As I said before, this is a relatively straightforward scan, and if you're doing it for screening in asymptomatic patients, you can certainly say, yep, we don't think that there's a AAA here. However, in patients with acute severe pain, you need to be a little bit more hesitant about that diagnosis. We traditionally start from the top in the transverse plane and scan, identifying first the celiac axis, which comes straight out of the front of the aorta towards the probe and then branches quickly into the splenic artery and the common hepatic artery. It's got the seagull sign as seen here on the top left of screen. Then just a centimetre or so below that, we reach the point where the SMA comes off of the aorta, and this is usually a nice round vessel just anterior to the aorta running parallel to the aorta, and it's usually surrounded by a nice white hyperechoic fat pad. That passes over the top of the left renal vein and behind the splenic vein. So there's quite a lot of vessels going on here, and it can be really tricky to work out what's going on. As we go below that level though, the aorta tends to be a single tube until it gets down to the bifurcation, which is actually a lot higher than you think. It's usually somewhere around the level of the umbilicus. And as the lordosis of the lumbar spine arches up, the aorta tends to become more superficial the further down you go towards the bifurcation. The middle part of the aorta can be very difficult to see sometimes if there's a lot of bowel gas, and this is quite a common finding. So we need to have other approaches, and it's important that you exercise good fasting if possible, or using graded pressure so that you're slowly pushing that bowel gas out of the way. Or if you're really struggling, you can attempt to use one of the lateral acoustic windows, such as through the liver or spleen, to try and get a good look at the aorta in long axis or short axis, but it can be quite far away when you use that approach. So be aware that it can be an incomplete scan. Now, when we do find an aneurysm, this is what they tend to look like. So you generally have a true lumen, and then you have the false lumen on the outside. There's usually flow within the true lumen, and then outside that there's typically a lamellated appearance to the clot, which is built up over time. And it's important that we don't get into the trap of measuring just the true lumen. We want to measure the true outside lumen from the tunica adventitia to the tunica adventitia, and not just the intima of the aorta. So in this picture, you could easily fall for this and measure the true lumen, which may be close to normal, whereas the outer measurement is actually quite large, and this would be a very high-risk aneurysm. The other thing is that as people get older, aortas tend to unfold and become quite ectatic, and so it can be really hard to line up the true long axis of the aorta with a straight probe, and so sometimes you do need to angle your probe to try and get that true long axis of the aorta, and sometimes it's impossible. So just be careful when you're measuring. Make sure that you're measuring a perpendicular slice of the aorta. We always recommend that you measure the aorta in transverse. Measuring any cylindrical structure in longitudinal is fraught and has a lot of error associated with it. So try and get a good transverse slice before you measure the aorta. Let's talk a little bit about the risk of rupture and what goes on here. So as you can see, the normal aorta is less than 2 centimeters. We don't really call it aneurysmal until it's over 3 centimeters. Between 3 and 5 centimeters, though, it's actually very unlikely that this particular aneurysm is going to be causing any issues for the patient. Obviously, it's not 0, but it's in the 1 or 2% range. And then once you get above 5 centimeters, there's a pretty exponential rate of rupture. And so over 6 to 7 centimeters, these are patients that need urgent referral, whereas between 3 to 5 centimeters, these are typically patients that will be referred on for formal imaging and surveillance. Here is the protocol that we have attached to the ultrasound machine, and this is basically what we want you to do, is to identify the aorta in transverse, high up in the epigastrium, try and identify the celiac axis, take pictures in transverse of the proximal, the mid, and then down below the SMA, and finally at the bifurcation, so that you can say that you've seen all of the aorta. And then we like to do a longitudinal view, ideally with the SMA, so then you know that you're looking at the true midline of the aorta, going from one side of the screen to the other, and try and make the aorta as horizontal on the screen as is possible. If you get good pictures, you can measure from outer wall to outer wall, making sure it's perpendicular. And if you really like, you can continue down and do the common iliac arteries as well, although these two tend to dive deep down into the pelvis after the bifurcation. It's important that when you document AAA or abdominal aortic findings, is that you comment on whether this was an adequate and complete scan. As I said before, bowel gas is our enemy, and it's common that we don't get a complete picture of the aorta. We may miss a few pieces here or there, and if that is the case, then you need to say this isn't a complete picture, so that it's clear to the people that come after you that this aorta hasn't been completely visualized. If you do see something abnormal, such as free fluid or retroperitoneal hematoma, then obviously that's very concerning, and that would necessitate an immediate CT scan. Right, so let's have a look at some AAA ruptures. So the features on ultrasound that we look for essentially is for a focal dilatation, so a saccular aneurysm of the aorta. These can be fusiform, we've got a long, slow opening of the aorta, and we look for a focal deficit between the true lumen and the thrombus, which is in the false lumen around the hematoma. This may be a very sharply demarcated thing, such as an aortic mural defect or an acute aortic sclerotic lesion, and you may actually see some thrombus floating within the false lumen. We're also looking around the back of the kidneys for some retroperitoneal fluid or possibly thrombus forming there, and if you see that, that can be very difficult to define, and if in a patient with severe pain, would want me to get a CT as soon as possible. Now, because we work in the modern era, there is a lot of these out there in the market, which is the endovascular aortic repair, where a vascular surgeon or an interventional radiologist has inserted a graft into the aorta in order to treat a AAA, and these grafts are great in that they don't require us to open the patient up with a large laparotomy and cause a lot of morbidity. The problem is they do tend to have a high rate of leaks, and so we need to be able to recognize that when we're using ultrasound, it can be very difficult to detect an EVAR leak, and our sensitivity is somewhere around about 70%. So if you really suspect this as a diagnosis, you really need to get a CAT scan. Now let's talk a little bit about aortic dissection. Dissection is a difficult beast in medicine because once you've thought it in, it's very difficult to think it out. And it's such a severe disease that once you've got to the point where you think that this is a possibility, then we really do need to do definitive imaging. Aortic syndromes, though, aren't quite as easy as they used to be. When I was in medical school, dissection was a dissection, and then they had a normal aorta. But what we've found, and recent research will tell us, that this is concept of a penetrating atherosclerotic ulcer, which is essentially a small defect in the intima of the vessel, usually around an atherosclerotic plaque, and that can sit there and cause not any symptoms at all, or it can become painful. And so patients, particularly elderly patients presenting with abdominal pain, often on CT are found to have these penetrating atherosclerotic ulcers, and then we need to know what to do with those. This can then progress to an intramural hematoma if there's a leak into the ulcer, into the wall of the vessel, and then finally the more traditional aortic dissection, where a flap of the wall is lifted up and that channels along and creates a false lumen within the aorta. So just be aware that that is some of the nomenclature that you'll see, particularly in the CT literature. What does a aortic dissection look like? Well, essentially what you're looking for is a flap within the lumen of the aorta. And these can be really obvious if you do see them. There's often a hyperechoic structure within the lumen which tends to wobble around with the heartbeat. And so you may be able to see that either in trans or in long when looking at the aorta. If you put colour flow on, you may show that there's actually flow within two different lumens, so the true lumen and the false lumen. And sometimes that flow will be going in opposite directions. So you'll put the colour flow on and you'll have a blue and a red flow Doppler pattern going on there, and that just doesn't make any sense, so that is likely to be a dissection. As I said before, our sensitivity for detection of dissection is quite low, somewhere in the 2/3 range, which is clearly too low for such a severe illness. However, our findings are quite specific when we do see them. If you see something that looks like this, it probably is a dissection. Now just remember that there are two types of dissections. There's type A and type B. Type A being the one that affects the ascending aorta and goes back around towards the heart, which is the critical one that we don't want to miss. And type B is the one that affects really just the descending aorta down into the abdomen, and these are traditionally managed medically. However, that can be a tough call on ultrasound alone, so once you've found anything, it does mandate a formal angiogram to work out what is actually happening and which other vessels are involved. So in terms of detecting dissection, there's a couple of other tricks that you can try. So type A dissections traditionally start at the aortic root, and they typically happen in folk that have abnormal aortic roots. So they can happen in people that have a bicuspid aortic valve, for example, or as is the case in this image, you've got someone with extreme aortic root dilatation. So if you look at the markers on the side there, this is the aortic root here, and that's 5 and that's 10. So this is about a 5 centimeter aortic root, which is clearly abnormal. They're usually in the sort of 2 to 3 centimeter range for most adults. And if you saw this and the patient we thought to have dissection, then that should trigger you to go on and get formal imaging as soon as possible. Trap for young players. If you look at this longitudinal view of the aorta, you'll see these two little bright echogenic structures within the aorta, and these do look like flaps within the lumen of the aorta. These are in fact artifacts, so it's not uncommon to see artifactual images within the aorta. So whenever you've got an anechoic structure like the aorta or bladder or gallbladder, and you've got a bright structure next to it, such as bowel or a gallstone or the duodenum, for example, or in this case, the actual vessel walls, you can get these side lobe artifacts, which can, by all the world, look like there's something within the black structure, when this is in fact an artifact. So just be aware of that, and once with a bit of training you can learn to pick these, and they tend to go away on different angles when you look at the same object from different angles. Alright, let's move on to other abdominal disasters. What else could be going on, and can ultrasound help in this scenario? So I think the really low-hanging fruit for ultrasonographic diagnosis in the ED is looking for bowel obstruction. So bowel obstruction is a relatively common problem, and we tend to have a good clinical intuition about who has bowel obstruction, though sometimes it can be more subtle, and ultrasound is really quite useful. So the technique for detecting bowel obstruction is really just to get the curvilinear probe, apply it to the abdomen, mow the grass up and down so you're covering the whole anterior abdominal wall, particularly in the area of maximal tenderness. And if you see this, which is distended bowel loops, which are full of fluid and they don't look normal at all. Typically bowel's got gas in it, you can't see it so clearly, you can't see the nice detail of the folds in the wall. This is what a bowel obstruction looks like. There are a couple of sonographic findings that we need to look for: distension of the small bowel over 2.5 centimeters, and what we call to and fro peristalsis. So as you watch this bowel, you'll just see it moving back and forth. The feces content's not actually going all in one direction, it's just sloughing back and forth as you watch it in a dynamic scan. I'll give you an example of that here. So here's a segment of bowel. You can see the peritoneum at the top, and this is the bowel which has got fluid content within it. And as you watch it over time, it's really not doing anything, it's just going back and forth, and we're getting a great view of the folds and plicae within the wall, which is very abnormal for bowel scan. So this is a distended, likely obstructed piece of bowel. It doesn't tell you where the obstruction is, it just tells you that you think there is actually an obstruction going on. And the other sign that we look for when we do detect a bowel obstruction is this. This is called the Tanga sign, which is essentially free fluid adjacent to the obstructed loop of bowel, and as opposed to the fluid which is in the bowel, which is round because it's in a circular object. If you see these triangular sharp pieces of fluid, anechoic little black triangles, that's fluid that's in between the bowel loops, and that is a bad sign and usually indicates that that bowel's not doing so well and that it's transutating fluid into the peritoneum. So be aware of that triangular versus round fluid in bowel obstruction. In the pediatric sphere, we sometimes see this, which is, I'll just play the video here, a piece of bowel. And if this is a longitudinal view of a short segment of the small bowel. And here's the transverse view of the same. And what you're seeing here is an intussusception. So you're seeing the bowel telescoping on itself. And there's not just the normal wall layers, there's actually a wall within a wall. So this is the outer wall, and then there's the inner wall of the intussusceptum in the middle here. So that's what an intussusception looks like. We sometimes call this the donut or the target sign. And traditionally this would be where the patient is most sore. And if you look at it in long axis, you can actually see that telescoping of the bowel as it sucks in on itself. Now, small bowel intussusception is actually not that uncommon to see on ultrasound. However, if you have a child that looks very unwell and is vomiting and has remarkably abnormal vitals, then this is one that would necessitate prompt referral to the pediatrics or the surgeons in order to try and get to the bottom of this. So they can be benign, but they can also be the more worrying obstructing types, which can lead to ischemia and obstruction, which obviously needs urgent care. I mentioned before that we will cover gallbladders in a later lecture. So this is a picture of a gallbladder. On the right of screen here we have the liver. This grey echogenic amorphous thing here is actually the gallbladder, and then that's full of sludge or pus, and there is a gallstone sitting down there in the neck of the gallbladder. And if you learn nothing else about acute abdominal pain and detecting gallbladders and gallbladder stones, is that stones are very common in gallbladders, but the ones that we really care about are the ones that are actually obstructing the gallbladder. If you see an innocent gallstone that's just floating around in the fundus of the gallbladder, that is probably not the cause of the patient's pain. It's the one that's stuck in the neck of the gallbladder. We'll cover that in a later lecture. So just be aware, these can be subtle to pick, and that is what it looks like when you see a gallstone stuck in the neck of a gallbladder. And lastly, we're going to touch briefly on appendicitis. This is a diagnosis which we don't really think that we should be making with point-of-care ultrasound as a general rule. On average, most patients have a bit of time and they can await for a formal ultrasound in the department, or if the clinical urgency arises, then they can have a CT to try and diagnose their appendicitis. Having said that, if you're scanning and you see something in the right lower quadrant that looks like an appendix, that is useful information, because if you can see it with your point-of-care ultrasound machine and you're pretty sure that that's where the maximal pain is and everything else fits with appendicitis, then there's a good chance that the sonographer around in the department is also going to be able to see this and maybe avoid the patient going to have a CAT scan, particularly in young patients or pediatric patients. If you can see it, then it's worthwhile referring for an ultrasound as a first-line investigation rather than a CT. We do spend a lot of time hunting for appendixes, and this can be quite time-consuming and probably is not something that most emergency docs want to spend too much time on, though sometimes they are quite obvious. And the most simple piece of advice is to put the probe where the pain is and gently move up and down and see if you can identify a tubular structure that appears to be the appendix. I'm not going to go into the actual sonographic features because that's beyond the remit of this course. Alright, that's AAAs and acute abdominal emergencies in a nutshell. Hit us on the comments if you have any questions. See you soon.